Chapter 8, Venipuncture Procedures. Chapter Objectives. Upon completion of Chapter 8, the learner should be able to do the following. Describe the patient identification process. Explain the use of venipuncture supplies in a typical venipuncture procedure. Describe when hand hygiene and gloving procedures should be used. Identify the most appropriate sites for venipuncture. Describe how to apply a tourniquet to a patient's arm and its effects on the venipuncture process. Describe the decontamination process for a venipuncture site. Describe the detailed steps of a venipuncture procedure. Describe the order of draw for collection tubes. Describe the importance of timed, fasting, and stat specimens. Explain at least 3 potential errors related to the incorrect use of venipuncture supplies. Blood collection process. There are essential steps that are a part of every successful blood collection procedure. Figure 8.1 is a flow chart that demonstrates the basic venipuncture process. Many healthcare facilities have their own very specific procedures to follow for this process. Employees must be trained to abide by each facility's protocols. In some cases, steps may occur simultaneously, such as checking the patient's physical condition while confirming the identification. In others, a problem may arise that prevents the healthcare worker from going further in the procedure, such as the verbal identity of the individual does not match the written documentation, or the supplies needed for the venipuncture have expired. Each step of the patient encounter must be evaluated carefully in a detailed manner, with care taken not to omit any of the essential components. However, the most basic and essential elements of all venipuncture procedures involve the following steps. Prepare yourself by cleansing hands and reviewing laboratory test orders. Number 2, approach, identify, and position the patient comfortably and safely. Number 3, assess the patient's physical disposition, including diet and or whether the patient is sensitive to latex or skin cleansing products. Number 4, select and prepare equipment and supplies. Number 5, find a suitable venipuncture site. Number 6, prepare or decontaminate the puncture site. Number 7, choose a venipuncture method. Number 8, collect the samples in the appropriate tubes and the correct order. Number 9, discard contaminated supplies in designated containers. Number 10, label the samples. Number 11, assess the patient to ensure bleeding has stopped. Number 12, decontaminate hands. Number 13, manage and document any special circumstances that occur during the phlebotomy procedure. Using standard precautions. Precautionary measures such as hand hygiene and the use of gloves should be considered routine procedures and are covered in detail in Chapter 4, Safety and Infection Control. These procedures are vital to the well-being of the patient and the healthcare worker and must be practiced continuously. Hand hygiene and gloving procedures are most commonly done as soon as the healthcare worker is in visual contact with each patient before beginning the actual procedure. This gives the patient a visual assurance of cleanliness and reinforces a safety-conscious gesture for both the patient and the healthcare worker. Glove removal and hand hygiene should be performed again after each patient encounter. Refer back to procedures 4.1, 4.2, and 4.3 for hand hygiene and gown, mask, and gloving techniques. These procedures should be mastered and practiced diligently by every healthcare worker who has contact with patients. Adherence to hand hygiene techniques, hand washing, or the use of alcohol-based hand rubs has been shown to significantly reduce outbreaks of infection, including antimicrobial-resistant infections, such as methicillin-resistant Staphylococcus aureus or MRSA. In addition, a clean pressed uniform or scrubs with a laboratory coat is comfortable attire and instills a sense of professionalism and hygiene, which is gratifying to patients and promotes a safer work environment. Each facility will have guidelines about when and where protective clothing is needed, so healthcare workers must follow their employees' protocols. Page 172 shows procedure 8.1, mentally preparing for the patient encounter. Rationale. To help the healthcare worker mentally focus on the importance of the individual patient and prepare for that specific venipuncture procedure. Equipment, phlebotomy supplies, personal protective or PPE equipment such as gloves, clean uniform, laboratory coat, etc. Test requisitions, writing pens, and a barcode reader scanner if needed. Preparation, Prepare and assemble your PPE, your phlebotomy supplies, test requisitions, writing pen, and appropriate patient information before the patient encounter and prior to the venipuncture process. Step 2, identify the patient properly. Step 3, wash or sanitize your hands with an alcohol hand rinse, then put on gloves. Procedure. Step 4, the healthcare worker needs a positive professional appearance, neat and clean, and temperament, optimistic and open-minded. Before beginning the patient encounter, take a deep breath, a deep cleansing breath before beginning. As you do this, focus on the individual patient and the request for the particular patient. Use the cleansing breath to center your attention on the upcoming venipuncture task as you temporarily remove yourself from other distracting factors in the workplace, such as noise, TV, telephones, or other conversations. Use your keen observation to determine any special circumstances or needs that the patient may have. Step 5, arrange and check phlebotomy supplies, test requisitions, writing pen, and appropriate patient information before beginning the patient encounter and venipuncture process. Step 6, if the patient information is incomplete on test requisitions, the healthcare worker may not be able to identify the patient correctly, or he or she may not know in which tubes to collect the blood. In such case, obtain assistance from a laboratory supervisor or a nurse before collecting a sample. Clinical alert. Remember that the use of gloves does not eliminate the need for hand hygiene, nor does good hand hygiene eliminate the need for gloves. Hands should be cleaned or decontaminated before and immediately after specimen collection procedures, and new gloves should be used for each patient. These are requirements for proper technique and for reducing the risk of transmitting microorganisms from one person to another. Be familiar with policies regarding precautions for handling blood and body fluids. All specimens should be treated as if they are hazardous and infectious, according to the standard precautions described in detail in Chapter 4. Assessing identity and approaching the patient. Test requisitions. Laboratory test requests are usually transmitted electronically or as a paper requisition. Electronic or computer-generated requests contain the same required information as paper requisitions, and in some cases, the medical record may be used as verification for a test requisition. However, each facility should have specific instructions for healthcare workers and their level of authority in making decisions about laboratory requests. Whatever the circumstances, the healthcare worker should be familiar with procedures used in his or her facility. Clinical alert. If the healthcare worker does not understand the test ordered, a supervisor, laboratory technologist, or nurse should be consulted before the procedure. Knowing which tests are requested helps the healthcare worker to prepare the patient appropriately and collect the specimen in the appropriate tubes and in the correct order. Failure to do so results in pre-analytical errors, misleading test results, and repeated venipunctures. Patient identification process. Positive patient identification is one of the most crucial responsibilities for which a healthcare worker is held accountable. See Procedures 8.2. In hospital settings, it begins with registration and admission when the patient is typically issued an identification band, usually worn on the wrist. Some hospitals use color-coded ID bands to denote specific patient conditions, such as red for allergy alerts, yellow for patients who are at risk for falling, and purple for patients with a do not resuscitate order. Whenever taking blood samples or administering medications or blood products, the Joint Commission recommends using at least 2 ways to identify patients. These identifiers can include name, date of birth, government issue ID with photograph, etc. However, it is not acceptable to use the following items as patient identifiers: hospital room numbers, bed tags, charts and holders near a patient or a table, or tags on IV equipment, because these items may not change as patients are moved or discharged, so they are not consistently reliable identifiers. Patient identification errors can occur at any time during the laboratory workflow process, including at the time of phlebotomy. For example, placing the wrong label on the specimen or as the specimen is being prepared for testing. For example, after centrifugation, when the specimen is divided into aliquots. The process of identifying patient varies slightly on the basis of the patient's location, inpatient, outpatient, or emergency room, the type of patient, pediatric or adult, whether the patient is conscious or unconscious, and the available information at the time, armband or picture identification. CLSI recommends that extra care is needed when identification occurs in certain high-risk situations, such as the patient does not understand the language. In this case, all efforts to find an interpreter must be made. Siblings or twins are being cared for at the same time. Patients with similar sounding names are being treated. Patients have common names, for example, Rodriguez, Smith, Jones. Patients have similarly spelled names, for example, CHO, CHOU, CHOW, CHIU, CHUNG, CHU, etc. Clinical alert. If there is a discrepancy in the identification process, the specimen should not be obtained until the identity can be verified. Discrepancy should be reported immediately. Identification errors can be life-threatening for the patient and pose significant liability to both the healthcare worker who makes the error and the healthcare facility that employs him or her. Never base identity on records or charts placed on the patient's bed or equipment. Identity errors occur because of inaccurate requisition, mixed up paperwork, or failure to follow identification procedures. All discrepancies should be reported to a supervisor. Figure 8.2, the basics of patient identification. Rationale, to use appropriate patient identifiers whenever taking blood samples. Equipment, not applicable. Procedure, patient identification involves at least 3 steps. Step 1, after introducing oneself and greeting a conscious patient, ask the patient to state his or her full name, spell the last name, and state his or her birthday. You may also request the patient's hospital identification number and/or home address. For example, sir, could you please confirm your full name and date of birth? Could you please spell your last name for me? Do not ask the patient yes or no questions. Ask open-ended questions, as in the example above, for a more reliable way to perform identity. Step 2, compare the information stated with the information on the patient's ID band. If the patient does not have an ID wristband, other forms of reliable, verifiable, person-specific identification may be used, such as government-issued photo, ID card, a nurse or parent. If the patient does not have an ID wristband, document the source of the identification. Step 3, confirm the information with the sample labels and/or requisition. If all 3 steps indicate the same identity, proceed with the rest of the specimen collection procedure. Refer to Chapter 5 for more information about requisitions. Box 8.1, Advances in Identification Systems. As mentioned in Chapter 5, barcodes are quick, accurate, cost-effective, and widely used for patient and specimen identification and tracking. Wireless technology such as radio frequency identification, which uses radio waves to transmit data, is also being used for patient identification and tracking specimens. Electronic identification systems have been shown to reduce identification errors. Some hospitals have also incorporated a small picture of the patient into his or her armband as an additional visual verification step. In addition, biometric technology such as fingerprints, voice recognition, iris or retinal patterns, and digitized signatures are emerging in the healthcare market for use as identification tools. Inpatient identification. Hospitalized patients, except those just entering the emergency room, must wear an ID wristband indicating first and last names and a designated hospital number, sometimes called a unit number. Hospital identification numbers provide a unique number for each patient and help hospital personnel to distinguish between patients with the same first and or last names. Information on an identification bracelet may also include the patient's room number, bed assignment, and the physician's name. As mentioned in Procedure 8.2, a 3-way match should be made with the patient's statement and spelling of his or her name, birthday, or address, the ID wristband, and the test requisition. Clinical alert. In some hospitals, there are special cases that involve patients with severe burns or in isolation, in which the identification is attached to the patient's bed rather than the arm. These are the only circumstances in which a healthcare worker may use a bed-labeled identification tag to confirm identity. This step should be followed up by a nurse's confirmation and appropriate documentation. Identification of patients who are sleeping. A patient who is sleeping should be awakened and have the patient identity verified before blood is collected. Verbal information should be compared with the information on the identification bracelet and the requisition labels. Clinical alert. The healthcare worker should not ask, "Are you Mrs. Doe?" because an ill patient on medications may mistakenly utter anything, nod, or answer yes. Therefore, remember that the best tactic is to ask an open-ended question. What is your name? Or please state your name and birthday. and let the patient reply. The patient must be correctly identified by his or her identification bracelet. If the patient does not have an identification bracelet, the nurse responsible for the patient must be asked to make the identification. The name of the nurse should be noted. Also, patients who are semi-conscious, comatose, cognitively impaired, or sleeping may jerk unexpectedly during the blood collection process, particularly as the needle is inserted into the arm. If the patient cannot be awakened, be prepared by seeking assistance from an authorized healthcare worker during the procedure to help secure the patient's arm. Identifications of patients who are unconscious, cognitively impaired, too young to identify themselves, do not speak the language, or have sensory impairments. There are also special cases in which healthcare workers must deviate from the standard ID procedure. A nurse, relative, or friend may identify patients in the listed circumstances: unconscious or comatose, cognitively impaired, too young to identify themselves, such as pediatric patients, cannot speak the healthcare worker's language, or have sensory impairments such as deafness. The nurse or relative should be asked to identify the patient by name, address, and ID number, and/or birthday. The name of the person identifying the patient and his or her relationship to the patient must be recorded. Again, this information should be compared with the information on the patient's ID wristband if he or she is an inpatient, and with their test requisition and/or labels to confirm identity. Any discrepancy should be reported to a supervisor. In the case of language barriers or sensory impairments such as deafness, attempts should be made to find an interpreter for non-English languages or sign language, if possible. However, the same ID procedure mentioned above may be used when an interpreter is not available. Refer to Chapter 1 for additional strategies to care for these patients. Emergency room patient identification. Patients often come to the emergency room, or ER, unconscious and/or unidentified. Most ER departments have similar identification methods, but all healthcare workers should be knowledgeable of the specific procedures at their own facility. Typically, a temporary master identification number or a unique hospital number attached to the patient's body by wristband or other suitable device may be provided until a positive identification can be made. When in the ER, the phlebotomist must often complete a requisition or sample labels, either electronically or handwritten, and it is imperative that all requisitions and sample labels can be cross-referenced to the ER patient's master ID number. This will link the specific laboratory test results back to the patient, and if he or she does not have a confirmed ID by name. Later, when the birth date, address, etc. are confirmed, the patient's name is usually electronically entered and linked to the master ID number, and from then on, the name and the other pertinent information is available. Healthcare workers in ERs must take extra care in the ID procedure because each situation has the potential to lead to be hectic and stressful. Many critically ill patients may be cared for simultaneously, and sometimes multiple unconscious, unidentified patients will need to have laboratory tests performed at the same time. Blood samples from the ER are usually considered as priority specimens or for stat processing, testing, and result reporting. Identification of neonates and babies. In a hospital pediatric setting, neonates and babies under the age of 2 may have an ID band placed on the lower leg or ankle rather than on the wrist, or both the ankle and the wrist. Whatever the case, CLSI recommends that a nurse, guardian, family member, or relative state the baby's name and date of birth so that it may be compared with the ID band and with the requisition. All the following elements should be confirmed: name of baby if designated, date of birth, baby gender, medical record number or unique identifier, mother's last name, or the last name used as registration. The name of the person who identified the baby and his or her relationship to the patient must be documented. Keep in mind that neonates do not always have a given name when they are first born, so their ID bands are typically linked to the birth mother. If the mother had twins, she may wear her own ID band plus ID bands of the preference each of her babies. In some circumstances, the baby may have a different last name that was provided upon registration. Whatever the case, all the criteria must match before proceeding with blood sample collection. Also, as mentioned previously, in the case of multiple births, extra care and sometimes additional procedures must be taken not to confuse the identity of siblings. Outpatient ambulatory patient identification. Ambulatory patients may be seen in the hospital clinics or physicians' offices and or may be receiving services such as diagnostic radiology and or laboratory testing, and they require positive ID but do not require armbanding. Ambulatory patient ID is handled in much the same way as previously discussed, except that as there is not a wristband to cross-reference. Other identifiers are used. Typically, an ambulatory patient is called by his or her name or a waiting room number into a private or semi-private blood collection area from a waiting room. Thus, ambulatory patient's identification takes more time because the patient first has to walk into the specimen collection area and be seated in a comfortable, safe phlebotomy chair or recliner. It is preferable for the identification process to take place in a private location since personal identification is being revealed. For a positive ID, the ambulatory patient must be asked to state his or her first and last name and birth date and spell the last name while the healthcare worker cross-checks this information with the test requisitions. Then he or she should be asked to show some form of identification. Healthcare, such as healthcare ID card, driver's license, or government issue ID. If the patient has an ID card available, positive identification using a three-way match, verbal ID, and requisition can occur in the same manner as with hospitalized patients. If there are discrepancies or problems with ID, a supervisor should be consulted prior to collecting blood samples. Patients who are undergoing outpatient surgery or receiving sedation or blood products must have an ID wristband, or if the armband is not possible, an ankle band. This is issued at registration, and at minimum, it should include the patient's full name and medical record number. Thus, for these patients, positive ID is essentially the same as for inpatients. Physical clues for assessment of the patient. As mentioned previously, factors related to physical or emotional disposition or age, pediatric versus geriatric, of the patient may affect the blood collection process. The healthcare worker can get clues about the patient's disposition by being observant and alert and by listening carefully. For example, if there is an empty food tray by the patient's bedside, it is likely that the patient has eaten recently, and documentation about the non-fasting condition should be made after confirming the observation with the patient. The following statement might confirm it with the patient. Mr. Jones, it looks like you might have finished your breakfast recently. Could you tell me when you last ate or drank anything? A clue about something unusual may come after talking to the patient or after the identification process has taken place. In the case of ambulatory patients, it is important to know if they have fainted during prior venipunctures. A simple question may evoke more information. For example, Mr. Jones, have you ever fainted during or after a blood collection procedure? If the answer is yes, the healthcare worker might move the patient to a recliner prior to beginning the venipuncture procedure. This assures a safer and more comfortable position in case he feels faint. Approaching a patient. Several professional and courteous behaviors and phrases can help make the patient healthcare worker encounter a smooth interaction. The first of these is a polite knock, no banging, on the patient's door before entering the patient's room. The healthcare worker should introduce him or herself and state which department he or she is from, such as the laboratory, and that he or she has come to collect a blood sample. Sometimes the healthcare worker may need to explain to the patient that the physician ordered the laboratory tests. The healthcare worker may also need to explain the procedure as supplies are being set up or as gloves are put on. Also during setup, standard precautions and hand hygiene, gloving, and other infection control procedures that were discussed in Chapter 4 should be carefully followed. For example, a phlebotomy supply tray should not be placed on the patient's eating table or bed because the bed is not a stable surface and because of the risk of contamination. Avoiding the transmission of microorganisms is a key factor in preventing hospital-acquired infections. As supplies are being readied and the vein is being palpated, the healthcare worker may try to alleviate some of the patient's fears. It may be reassuring to purposely show the patient that the supplies are new and unused. Clinical alert. If a physician, clergy, or nurse is consulting with a patient, the specimen collection procedure should be delayed until the consultation is complete. The physician-patient relationship has priority over the phlebotomy procedure unless the request is for a timed or stat specimen. If either of these is the case, ask for permission to proceed. When friends and relatives are in the room, politely explain to the patient that a blood sample is needed and ask whether the guest would mind leaving the room temporarily. The patient may also give permission for the guest to stay during the venipuncture procedure. Now on page 180 is box 8.2. Equipment selection and preparation. Supplies for venipuncture. Being prepared means having all supplies readily available. As discussed in more detail in Chapter 6, supplies for venipuncture differ according to the method used, i.e. evacuated tube system or winged infusion butterfly system or syringe method, and the tests that have been ordered. Supplies common to most methods of blood collection are the following: written, printed, or electronic laboratory requisitions and/or labels, marking pens, gloves, non-latex tourniquets, alcohol, pads, skin disinfectants, disinfectant swab sticks for blood culture, skin preparation, safety needles with single-use evacuated tube holders and winged infusion sets, safety syringes and syringe transfer devices, blood collection tubes, plastic capillary tubes with tube sealer, non-latex bandages and sterile gauze pads, glass microscope slides, puncture-proof sharps container. Supplies should be readily available and selected just prior to the procedure. Positioning of the patient. It is important to make the patient comfortable and safe and to choose the least hazardous site for blood collection by skin puncture or venipuncture. Healthcare workers should know about useful devices and the position and location of veins. Venipuncture site selection. The most common sites for venipuncture are in the antecubital area of the arm just below the bend of the elbow, because this is where the median cubital, cephalic, and basalic veins lie close to the surface of the skin and are most prominent. The least hazardous site for venipuncture should be selected when possible. Page 184 and 185 shows various tools and things that are used for blood collection. To reduce the risk of puncturing an artery or injuring a nerve, CLSI recommends that vein selection be considered in the following order. Refer to figures 814, 815, and 816. Number 1, median cubital, sometimes called the median vein, most commonly used veins for venipuncture because it is the easiest to obtain blood from, has been reported to be less painful and less prone to injury if the needle is not placed precisely in the vein. It is best to check both arms for suitable median cubital vein prior to using other choices. Number 2, cephalic vein on the outer edge of the thumb side of the arm. Number 3, basalic vein on the inside edge of the antecubital fossa area, the side of the pinky finger. It is in close proximity to the median nerve and the brachial artery, so the other choices are preferable. Sometimes the phlebotomist has to check both arms to choose the least hazard site. Only use the basalic vein if the other veins on both arms are not prominent. Palpating the entire antecubital area enables the healthcare provider or worker to get an idea of the size, angle, and depth of the vein. The patient can assist in the process by holding his or her arm straight or slightly bent at the elbow. It is not recommended that the patient make a fist and/or pump up the vein because opening and closing the fist multiple times can lead to hemoconcentration. However, in some cases, making a fist once and keeping it closed for a short period of time, not pumping the fist, can facilitate the venipuncture until blood flows into the tube. Also, some patients prefer to make a fist as a means to remain steady or still during needle puncture. If so, ask the patient not to pump their fist and remind them to open it as soon as the needle puncture occurs or blood flow begins. Because selective veins may also be used for blood product transfusion, infusion, or therapeutic agents, sometimes physicians request that veins have restricted use or are reserved for those purposes only. Healthcare facilities and educational programs may vary by specific procedures, so healthcare workers should follow the procedures at their respective sites. Alternative puncture sites. Alternative sites for blood collection when the antecubital area cannot be used are hand veins, and in some cases, with proper training and physician approval, foot veins. In addition, Chapter 9 discusses the alternatives of capillary fingerstick specimens. Hands. Veins on the dorsal side of the hands or wrists are acceptable venipuncture sites if the median cubital, cephalic, or basallic veins are inaccessible on both arms. Veins in the wrist and ankle tend to move or roll aside as the needle is inserted. Therefore, it may be helpful to have the patient extend the hand or the foot into a position that helps hold the vein taut. Clinical alert. Serious patient injury can occur due to excessive probing, poor site selection, deep needle penetration all the way to the nerve, or if the patient suddenly moves or jerks his arm during the venipuncture procedure. If the patient complains of severe pain during the procedure, the needle must be removed immediately and the procedure discontinued. Assistance should be sought from a nurse or supervisor. Only a physician can evaluate whether or not nerve damage has occurred. Nevertheless, the incident should be documented. Figure 817 depicts the proximity of nerves in relation to the veins. Arteries do not feel like veins and should not be confused. Arteries pulsate, are more elastic, and have thick wall. Accidental arterial puncture can result in excessive bleeding and hematoma, which is bruising caused by localized bleeding. If an artery is punctured, the needle should be removed immediately and direct pressure should be applied to the site for at least 5 minutes or until the bleeding has stopped. A supervisor or nurse should be notified. Clinical alert. The patient's arm veins cannot be used for venipuncture in following circumstances: IV lines in both arms, burned or scarred areas, areas with a hematoma, casts on arms, thrombosed veins. Thrombosed veins lack resilience, feel like a rope cord, and roll easily. Edematous arm, swollen area because of excessive amounts of tissue fluids. Mastectomy on one side only. Use of the arm on the unaffected side is acceptable for venipuncture. Mastectomy on both sides. Unless approved by a physician, neither arm should be used because of fluid accumulations. Sometimes, if no other puncture sites are available, the doctor may allow blood to be collected, and the situation should be documented. Again, hands. Veins on the dorsal side of the hands or wrists, the back side, are acceptable venipuncture sites if the median, cubital, cephalic, basallic veins are inaccessible on both arms. Veins in the wrists and ankles tend to move or roll aside as the needle is inserted. Therefore, it may be helpful to have the patient extend the hand or foot into a position that helps hold the vein taut. Venipuncture in small veins is facilitated by the use of a 21 to 23 gauge safety butterfly needle. By careful placement of the hand or wrist in a comfortable and stable position, sometimes with the use of a clean towel underneath to raise the wrist slightly, and by anchoring, position the vein with one hand, holding it taut while the needle insertion occurs with the other hand. Ankles or feet. Ankle and foot veins on the dorsal or upper side should be used only if arm veins have been determined to be unsuitable and if the healthcare worker has been trained or authorized to do so. Arm veins are sites preferred over foot or ankle veins because coagulation and vascular complications tend to be more troublesome in the lower extremities. Thus, foot and ankle veins should not be used for cardiac or diabetic patients. Some hospitals do not allow the use of lower extremities, foot and ankle, for blood sampling sites. Other hospitals allow sampling from these sites only after permission has been granted by the patient's physician and after the healthcare worker has been properly trained, if allowed. If allowed, a smaller needle is again recommended. It can take time to find a suitable puncture site in some patients. However, performing a venipuncture on a non-traditional site simply because the vein looks good is hazardous. Increases the risk of injury to the patient and will likely result in legal liability to the phlebotomist in a healthcare facility. Hard to find veins. Sometimes it's very difficult to feel a suitable vein. Warming the puncture site helps facilitate phlebotomy by increasing arterial flow to the area. Several warming devices are available commercial that are quick and easy to activate and provide localized heat to the potential venipuncture area. Another method is to use a clean towel or a washcloth heated to about 42 degrees Celsius. When the warm towel is wrapped around the site for 3 to 5 minutes, the skin temperature can increase several degrees. The wrap can be encased in a plastic bag to help retain heat and/or keep the patient's bed dry. The healthcare worker may leave the warm wrap on the patient until he or she collects specimens from other patients and then return to the original patient after several minutes. Another method to improve vein location is if one cannot be felt initially is to have the patient dangle his or her arm by their side in a downward position for 1 to 2 minutes. This allows the blood to fill the arm veins to capacity. Then a tourniquet may be reapplied and the area repalpated. Clinical alert. For hand vein punctures, the posterior or dorsal side, the back of the hand, the side that shows off a wedding ring, should be used. Do not use the anterior side or the palmar venous network in the wrist because nerves are easily injured by needle probing this area. Tourniquet application and cleaning the puncture site. A tourniquet, preferably single-use, latex-free, makes veins more prominent and easier to puncture by causing venous filling. Tourniquet slows down blood flow toward the heart so that it pools or gathers in the veins. A soft rubber tourniquet about 1 inch, 2.5 centimeters wide, and about 15 to 18 inches or 45 centimeters long is most comfortable for patients, affordable, and easy to use. And it comes in a variety of colors. Brightly colored tourniquets are preferred to skin tone tourniquets because they are more noticeable and thus less likely to be left on or near a patient accidentally. Practices differ slightly on the use of tourniquet. Experienced healthcare workers are often able to find a puncture site by palpating the antecubital area without a tourniquet, then applying the tourniquet just before the needle puncture. However, less experienced healthcare workers are encouraged to take their time in finding a suitable puncture site, so it may be necessary to apply the tourniquet while palpating the antecubital area, then release the tourniquet for a short period of time while the supplies are ready, then reapply it before the needle puncture. A tourniquet should not be left on for more than 1 minute. Procedures 8 through 3 provides basic steps for applying a tourniquet, but again, healthcare workers should follow the procedures at their facilities. Pages 192 and 193 shows procedure 8.3, the use of a tourniquet. Venipuncture methods: evacuated tube system and winged infusion system or butterfly method. CLSI recommends that venipuncture specimens be collected with a system that enables blood to flow directly into the tubes. Evacuated tube systems and winged infusion systems, such as butterflies, are widely available. Equipped with safety devices, come with needles of various sizes, and comply with these recommendations. Procedure 8.5 demonstrates a basic venipuncture technique. However, some healthcare facilities and/or educational programs may vary their venipuncture procedures slightly. Healthcare workers should follow those procedures accordingly. Pages 194 shows procedure 8.4, cleaning the puncture site. 195 shows procedure 8.5, performing a venipuncture. 196, continuation of page 195, showing a venipuncture. And 197 is a continuation of showing a venipuncture. 198 is still a continuation of showing a venipuncture. 199 shows the completion of the procedure. Special considerations for the winged infusion butterfly method. A safety winged infusion system, butterfly needle assembly, or scalp needle set can be used for certain patient populations or for particularly difficult venipunctures. This type of method may be useful in the following circumstances: patients with small veins, pediatric or geriatric patients, patients having numerous needle sticks, such as cancer patients, patients in restrictive positions, such as traction and severe arthritis, patients who are severely burned, patients with fragile skin and veins, patients who specifically request it because they feel it is less painful. Short-term infusion therapy. Special notes. Use of winged infusion or butterfly systems requires training and practice because of the small tubing involved, but they are widely used because patients report that they are less painful than other methods. While the procedural steps are the same as for the evacuated tube system, there is a difference when tubes are filled. Because the tubing from the winged infusion system contains some air, the first tube will underfill with blood by 0.5 milliliter. thus affecting the additive to tube ratio. In collection tubes that contain anticoagulants or other additives, therefore, a non-additive tube should be filled first. Then the order of draw can follow, the usual order recommended. Follow the procedures in each healthcare facility for the use of this system. This is especially important for coagulation testing when only one tube is required. In this circumstance, many hospitals require a discard tube to remove the air displacement prior to collecting the sample tube for coagulation studies. Healthcare workers should be extra cautious as the butterfly needle apparatus is removed from the patient because it tends to hang loose on the end of the tubing and may sometimes recoil unexpectedly. Therefore, the safety device that covers the needle should be activated immediately. Failure to activate the safety devices correctly, as described by the manufacturers, may result in higher incidence of needle stick injuries. Pages 200 and 201 shows procedure 8.6 syringe method. Clinical alert when doing the syringe method. Do not panic if blood does not flow immediately after the puncture is made. The following suggestions may help. Recheck the needle placement and vein by palpating gently above the needle insertion site. Change the needle position slightly, but do not probe. That is, pull gently outward or push gently forward, or rotate slightly so that the bevel is positioned correctly in the vein. These should be small movements so as to minimize the risk of some complications. If no blood flows, attempt the collection from one other side. Do not make more than 2 attempts. Page 202 shows procedure 8.6 or the syringe method continued. Clinical alert. Use once and discard immediately. Needles, lancets, syringes, and other blood-letting devices, collectively called sharps, that are capable of transmitting infection from one person to another should be used only once, then immediately discarded. Sharps must be discarded in puncture-resistant containers that are easily accessible, located in areas where they are commonly used, and have proper warning labels. Blood tube holders should be used only once because of the potential needle stick hazards associated with double-ended needle at and after disposal. Shearing or breaking of contaminated sharps is illegal and strictly prohibited. Bending, recapping, or removing contaminated needles is not acceptable practice. Other contaminated supplies such as gauze, alcohol wipes should be discarded in designated biohazard containers depending on the workplace setting and the health facility's procedures. Order of draw for blood collection tubes. Because multiple blood tests are usually ordered simultaneously for a patient, it is common for multiple tubes to be collected. Many tubes contain various additives. Therefore, collecting blood sample tubes in the correct order reduces the chance of erroneous laboratory test results due to additive carryover from one tube to the next. Additive carryover may cause erroneous laboratory test results. During the actual venipuncture process of filling tubes with blood, tube manufacturers and the Clinical and Laboratory Standards Institute, or CLSI, recommends the following specific order of draw. When collecting blood in multiple tubes, either glass or plastic, via the evacuated method or the syringe transfer method. Blood culture tubes, number 1, or blood culture vials. Blood cultures are always drawn first after special skin decontamination procedures to decrease the possibility of bacterial contamination. Number 2, coagulation tube, or light blue closure. Number 3, serum tube, with or without clot activator, with or without gel, red or speckled closure. Glass non-additive serum tubes can be filled before the coagulation tube. However, plastic serum tubes containing a clot activator may interfere with coagulation tests. Number 4, heparin tube, green closure, with or without gel plasma separator. Number 5, EDTA tube, purple lavender closure, used for routine hematology tests. Number 6, glycolytic inhibition tube, potassium oxalate, sodium fluoride, or lithium iodide acetate, heparin, gray closure. On page 204 is a chart with the order of draw from multiple tube collections. Chpt8 3. Other issues related to filling the blood collection tubes. During the venipuncture procedure, care should be taken that the additive or anticoagulant present in one tube does not come into contact with multi-sample needle as the tubes are changed. To minimize the transfer of anticoagulants from tube to tube, holding the tube horizontally or slightly downward during blood collection is recommended. If an anticoagulant is inadvertently carried into the next tube, it may cause erroneous test results. Be attentive to the fill rate and the volume in each tube. Evacuated tubes with anticoagulants must be filled for the proper mix of blood with anticoagulant, i.e. the blood to additive ratio. Although the use of syringe should be restricted to special cases, occasionally a large volume, more than 15 milliliters of blood, needs to be drawn using a syringe. Sometimes more than one syringe of blood is needed. In this case, it is best to use a winged infusion set and ask for assistance transferring the blood to tubes while a second syringe is being collected. Thus, one healthcare worker is collecting the sample while the other is transferring the blood from the first syringe into the tubes. This reduces the risk of blood clotting in the syringe. Also, closure stoppers on the sample tube should not be removed to inject blood from the syringe. Rather, a transfer device should be used to transfer blood into the tubes. Clinical alert, special considerations for coagulation testing. Each healthcare worker should use the procedure adopted by his or her facility. However, if coagulation studies are the only test ordered and a winged infusion butterfly system is to be used for collection, a discard tube should be collected before drawing the citrate tube. This is the only way to rid the specimen of the air in the winged infusion tubing. If this air in the dead space enters the citrate tube, it causes an inaccurate blood to citrate ratio and false test results. When a syringe method is used to collect a large volume of blood, usually 2 syringes are used, so blood from the second syringe should be used for the coagulation tube as it is less likely to have begun clotting. Because coagulation tests require specific plasma concentration of sodium citrate, overfilling the tube may cause artificial results or false short clotting times. If a tube is underfilled, the opposite occurs, and artificial results indicate falsely prolonged clotting times. Immediately after collection, coagulation tubes should be mixed gently to prevent clotting in the tube. However, overmixing by an excessive number of inversions or vigorous mixing can lead to platelet activation and shortening of clotting times when tested. Specimen identification and labeling. Completed labels should be firmly attached to the patient's specimen in the presence of the patients. Labels must accompany all blood specimens. The healthcare worker may write directly on the container label if necessary. Commercial collection tubes may have affixed blank labels for this purpose. Similarly, hospitals often use computer-generated labels for collection tubes. However, capillary tubes, micro-collection tubes, and vials or other containers without labels must be identified either by labeling them directly with a permanent felt-tip pen, wrapping an adhesive label around them, or placing them into a larger labeled test tube for transport. In some cases, small electronically generated adhesive labels with printed information are available with detachable from the requisition form. Whatever the type of label may be, handwritten or electronically generated, blood sample labels should be consistently include the following information: the patient's full name, patient's identification number, date of collection, time of collection, identification of the persons who collected the sample, and patient's room number, bed assignment, or patient status, which is optional. Labels for blood specimens. Specimens should be labeled, usually barcoded labels, immediately at the patient's bedside or ambulatory setting before leaving the patient. Laboratory procedure manuals should contain explicit instructions about labeling requirements and reconfirmation that the samples and patient have the same identity. Supervisors should spend ample time not only training new employees in correct identification and labeling practices, but also observing as they perform the steps. Sometimes labels need to be placed in specific locations on a table due to automated processing and analytical requirements. Remember, tubes should never be pre-labeled because they may be erroneously picked up and used for another patient, which could cause significant errors. Also, a different healthcare worker may complete the venipuncture if the initial healthcare worker is unsuccessful. In that case, the pre-labeled tubes may display the initials of the first healthcare worker. and therefore be inaccurate. In addition, if the pre-labeled tubes are not used, tearing off the old or unused label may be difficult because of the adhesive. Thus, either a new label from a different patient would have to be placed on the tube with a partially torn label, or the unused tube would have to be discarded. Either option is unsatisfactory, messy, and wasteful. Clinical alert. Before leaving the patient, be cognizant of the following issues. The healthcare worker should always make sure the bleeding has stopped. The sample tubes are correctly labeled, identified, and placed in a secure location for transport. Supplies are safely disposed of or stored. Hands are clean, that the patient does not feel faint, and has been thanked for their cooperation. This must occur before leaving to draw blood from another patient. The date and time are necessary information because physicians need to know exactly when the specimen was drawn so that they may correlate results with any medications given or with changes in the patient's condition. Requisition forms only indicate the date and time when a laboratory test was ordered, whereas the label indicates the date and time when it was collected. The healthcare worker's initials are necessary to help clarify questions about the specimen or a patient if any arises during laboratory processing or testing. All supplies and equipment must be removed from the patient's bedside. See Procedure 8.7, which is on page 207. Clinical alert. Excessive bleeding after a venipuncture procedure may be due to an inadvertent or accidental arterial puncture. Although this is a rare occurrence, it can lead to serious complications for the patient. So the healthcare worker should call for assistance from a nurse or supervisor to assure that the bleeding is adequately contained. Also, bandages are not recommended for infants or very young children because of possible irritation and the potential of swallowing or aspirating the bandage if it comes off. Prioritizing patients. During the course of a day's work at a busy hospital or clinic, a healthcare provider may have to make decisions about the order in which blood work is obtained. Priorities must be set and adhered to, whether they concern the order in which certain blood tests are drawn on a particular patient or which patients are to be drawn first from among a group. If these distinctions are not made properly, test results can be affected and interpretation of results may be difficult. Timed specimens. If a test is ordered for blood sample collection at a particular time, the healthcare worker is responsible for drawing the blood as near to the requested time as possible. Time samples are important for various reasons, such as timing of administering medications, such as digoxin, therapeutic drug monitoring to establish drug dosing, such as chemotherapy agents, fasting restrictions, such as glucose, or circadian rhythms, such as cortisol. Physicians will make medical decisions based on the laboratory values at the specified time. Time specimens are crucial for TDM because the laboratory results taken from blood samples for TDM are used in establishing patients' drug dose. STAT, or emergency specimens. STAT blood samples must be collected and delivered to the laboratory for testing as quickly as possible. These terms are used because the patient has a medical condition, possibly life-threatening, that must be treated or responded to as a medical emergency. Some healthcare facilities utilize other terms that indicate a priority status, as soon as possible, or ASP, for example, but not a critical emergency status. Familiarity with each facility's terms related to the order of priority is essential. Box 8.5 shows ideas for improving venipuncture practices. All members of a healthcare team should strive to improve phlebotomy practices. Sometimes this involves coordination across departments and hospital units. A few suggestions for improving efficiency and quality include coordination of laboratory requests among all staff physicians and nurses working with the patient to reduce duplicate and triplicate laboratory orders, possible modifications to the laboratory test panel menu, and better education of physicians to be aware of all the tests on each laboratory panel. The laboratory could be notified when multiple time tests are ordered. For example, if a patient needs a hemoglobin test at 2 p.m. and a glucose at 3 p.m., coordinating the times and drawing both specimens during one venipuncture may be possible. Common analyses that are time-dependent are glucose tolerance tests and drug levels, so coordination of other venipunctures should be carefully considered. Reassessment of STAT test orders to make sure they are clinically necessary. Therapeutic drug monitoring, or TDM, which is timed laboratory analysis of serum drug levels to determine adequate therapeutic dosing, should be coordinated among laboratory, nursing, and pharmacy personnel. The laboratory should be aware of patient transfers. The number of times that a patient can be punctured should be monitored. Generally, a healthcare worker should not puncture a patient more than twice before calling for a second opinion. The number of times that a patient can be punctured in one day should be coordinated and minimized. The total volume of blood that can be drawn daily from a patient, especially for infants and children, Appendix 4, and critically ill patients must be monitored. When conversing with the patient, healthcare workers should restrict discussion about a patient's clinical information to very basic facts about the tests that have been ordered. It should be emphasized that the patient's physician ordered the test and can answer questions about them in more detail. Procedures for documenting a patient's refusal to have blood collected should be established. All patients have a right to refuse treatment. Explain to the patient that laboratory results are used to help the physician make an accurate diagnosis. Establish proper treatment and monitor the patient's health status, and the patient's cooperation would be greatly appreciated. If the patient continues to refuse, remain professional and acknowledge his or her right to refuse. Documentation of the refusal should be made and the patient's physician notified. Guidelines for specimen rejection, i.e. criteria that relate to the suitability of a specimen for testing or when it may not be used, should be periodically reviewed. These policies generally include circumstances related to inaccurate identity, collection in the wrong tube, inadequate volume of blood in the tube, hemolyzed or clotted specimens when they are not supposed to be, improper transportation or storage, use of outdated, expired supplies, contaminated samples, patient did not comply with diet restriction, or time samples that was collected at the wrong time. In all these situations, the healthcare worker should learn how to proceed with corrective actions and error documentation based on SOPs for each facility. Communication, honesty, and ethical professional behavior are keys to an efficient, reliable healthcare environment. Refer to Chapter 7 for further discussion about pre-examination, pre-analytical complication. This concludes Chapter 8.